So good morning, good afternoon, and good evening. We've got participants from the UK, so thank you very much indeed for those people joining. Much appreciated. I wanted to introduce this first of a two-part series that we're very privileged to have Dr. Rob joining us to go through. Talking about obviously food sensitivities, which is our bread and butter, but also now the gut barrier panel that we've had out there for over a year, and as some of you will have been picked up as well, the addition of the LPS marker in June of this year as well. So very lucky to have Dr. Rob to go through that from his clinical perspective, to go through his experiences of using the test, which is invaluable. And that's one of the things I like to do is work with kind of key opinion leaders who are actually practicing versus just on the circuit, as it were, of conferences. And with Dr. Rob, that's one of the many advantages that we have of working directly with him. So without further ado, I'll pass across to Dr. Rob to go through. Any questions that you've got, stick them in the chat, and I'm always happy to answer them. And if I can't answer them, we'll get to Dr. Rob to have a go at the end. So without further ado, Dr. Rob, over to you.
Thanks so much, James. It's always a pleasure and an honor to work with you and to be able to talk about your test. Essentially, I believe the KBMO FIT test with the gut barrier function panel is a baseline test that everybody who does functional nutrition or functional medicine, who's thinking about just adding nutrition and testing and not guessing in their practice, should really consider to put in their toolbox. It's really revolutionized the way I look at specific conditions with patients. Little brevity, I have a chiropractic background, so I do have a lot of musculoskeletal conditions, and it has been to share with my chiropractic brethren, breathtaking to watch them really understand how a food sensitivity can increase the incidence of musculoskeletal injury and or muscle inflammation, and clearly the gut barrier panel. I mean, if we have a break in our gut barrier, it just leads to a plethora of deleterious conditions. Got about 60 slides, so I am a slide guy. I'm going to try and do them in 40 to 45 minutes because I do believe the gems after I share what is going on in a test and a quick case study is the extemporaneous time that I have with you. So I do want to spend some time on that. Okay. And I wanted to put this up here because sometimes some people have to leave after 30 minutes or 35, so you'll see this slide twice. If anybody's interested, James has been very kind and he's offering a discount for you. So you should try it. And I do recommend, if you haven't tried it, to please try the test. That was the game changer, if you will, for me also, to really see, wow, here's a guy, at least I think I take care of myself, someone who takes care of themselves. Fortunately, did not have any gut barrier panels, but did have some food sensitivities. And that in itself is a whole conversation. So James has been kind enough once again to discount it. You'll have this opportunity at the end to see that. And let's move on. Hippocrates once said about 2,500 years ago that all disease begins in the gut, the father of medicine. But Alessio Fasano in the year 2000 changed it just a little bit and said all disease begins in the leaky gut. Here, indeed. But it took 2,500 years for us to take that next step. They're both correct. This is just a little more precise to what we do. Now, here's my Dr. Rob's gut matrix. I use this in all my presentations. I believe that the gut is the epicenter of your health. 80% of your immune cells are in your gut. It's where your macro and micronutrients are absorbed. When we talk about the gut, we're really talking about the intestinal tract, the small and the large intestine. The small intestine is interesting in that it's really not small. It's 90 to 95% of the length. It's a single layer epithelial cell that has the thickness of a wet paper towel. So you can see already how easy it is to perforate. It should be permeable, or if you will, to be precise, it should be semi-permeable. Things that can go wrong in the gut would be clearly yeast, which you would test for Candida. In addition to Candida, you would also, yeast and fungus, you would want to look at dysbiosis. Dysbiosis is the leveling of good and bad bacteria. You need about 85% good bacteria, 85.1% not to have dysbiosis. There's a direct correlation between dysbiosis and Candida. interestingly enough, you have that candida, it usually leads to dysbiosis, and this can start you on that trek down that slippery slope of having failing gut health. One more thing that I'm going to throw out there and seed you for a future conversation is candida. 97% of SIFO, small intestinal fungal overgrowth, is candida. Leaky gut syndrome means that the gut is too permeable. What should pass that small intestine very simply is water, vitamins and minerals, and small digestible food particles. One of the overriding reasons for a proverbial leaky gut would be the increase or the presence of food sensitivities. And food sensitivities, we're talking about one that stimulates an immune response and also an inflammatory response. Some more brevity in the overview. If you can see LPS, lipopolysaccharide, I believe that's the bandit of a gut. Once that's expressed, it's an endotoxin. Again, it leads you down a tremendous slope. It really can increase the incidence of leaky gut, not only increase the incidence and evidence of leaky gut, it also can cause a lot of autoimmune conditions. Lipopolysaccharide holds gram-negative bacteria on the inside of the intestinal wall. So if you're seeing LPS expressed in some way, shape, or form on the gut barrier panel, you can rest assured that there's a good possibility that gram-negative bacteria is also expressed in the bloodstream, and 80% of gram-negative bacteria is pathogenic. There's a gut-to-liver axis, so if you want liver dysfunction, there's a direct tie. There's a gut to insulin, blood sugar problems, insulin resistance, prediabetes. There's also a gut to body composition. People seem to have a more corpulent body composition when they have a leaky gut. There's a gut to autoimmune, which is evidenced by thyroid. And for me, again, having a chiropractic background, there's a gut to joint, gut to spine axis. Hopefully, we will be able to cover that in some of our upcoming webinars. The overview there is there's a release of cytokines when you have leaky gut. Cytokines lead you down a slope of arthritis and joint pain. And also, when you have leaky gut, the gut releases MMPSs. MMPSs, matrix metalloproteinases, are your body's own proteolytic enzymes that eat fibrocartilage at the time of injury. Fibrocartilage is the basis for what a disc is compiled of and composed of. And lastly, really isn't last, but the superhighway to health, the gut to brain, the brain to gut. Whatever you do to your gut, you do to your brain. Whatever you do to your brain, you do to your gut. Gut on fire means brain on fire. It truly explains why people sometimes, when they have a leaky gut or food digestion, have bloating, gas and bloating, and also which leads to brain fog. So we could spend all day on this. This really ties everything up. Incidentally, there's now a gum to gut microbiome, something to talk about. There's a gut to kidney microbiome, and there's a gut to skin microbiome. So let's talk about triggers of increased intestinal permeability. The number one would be antibiotics. Nobody here is saying that I'm an anti-antibiotic, if that's not a misnomer, but antibiotics are nuclear weapons. They blow up all of your bacteria, both good and bad. So rest assured, even though we need them in instances, antibiotics need to be treated and can have some residual damage to the gut lining. Acid blocking drugs, proton pump inhibitors. The average American takes them for months, years, and some even decades. It's only supposed to be prescribed for 4 to 6 weeks. Acid blocking drugs are as detrimental as antibiotics in many instances in that they cause leaky gut. They cause an array of things that damage the gut and inclusive of the blood-brain barrier. NSAIDs, non-steroid anti-inflammatories, they do decrease pain, but they impair healing. Some of the nutraceuticals that I'll recommend will decrease pain and promote healing. So NSAIDs obviously want to limit or eliminate that exposure. Heavy metal exposure, environmental toxins have been documented in the literature. Concussion. 60% of concussion patients have a gut issue, whether it be small intestinal bacterial overgrowth and or leaky gut, cesarean birth, liver toxicity. Remember the bidirectionality between the gut and the liver and the gut dysbiosis, and food sensitivities. Well, some brevity. I think most people here are already using the FIT test, but food sensitivities, and here's your takeaway. This is what I tell patients. Food sensitivities, I believe, are maybe one of the main reasons for hidden and or chronic inflammation. My credo is to manage and modulate inflammation. Food sensitivities are interesting where they vary from a food allergy. Food allergy is immediate. Everybody knows what it is because we've all been on a plane where the flight attendant has said, please do not eat a peanut. Someone's highly allergic. It's an IgE-mediated response, as we all know. Food sensitivity is an IgG-mediated response. It typically takes up to 3 days to see the symptomology from the fact that we have a food sensitivity. So as a practitioner, how can I really ascertain what that patient ate 3 days ago to now to really ascertain that inflammatory status? And how, as a patient, having taken the test, do I know? It really speaks volumes to wanting to use the FIT 176 test, in that it really encompasses the idea of testing and not guessing. Again, yeast and bacterial overgrowth, candida, we're supposed to have some candida, but an overgrowth leads us down that slope that we've talked about. Chronic stress, sleep deprivation, chronic inflammation, alcohol, gluten, dairy, no brainers there, sugar, artificial sweeteners. And I think it's a great ad, which sometimes James and I don't talk enough about, is testing for food additives and emulsifiers. Because when you look at the average American, 63% of the calories that they consume is from ultra-processed food. And part of that ultra-processing is adding food additives and emulsifiers too. So many people are exposed. This slide, to me, just I put in because I want to express how the food can damage your gut and the food speaks to your brain. What you eat can stimulate your microglial cells, which are your macrophages of your central nervous system. So what you eat speaks volumes to your whole digestive and, of course, your circulatory system. Good food can promote health signals. Bad food can promote inflammation. Obviously, we all need to choose wisely and need to know what foods do not stimulate the inflammatory cascade. The gut-to-brain axis has been documented in the literature, but when you realize that the basis for a lot of mental health disorders, all neurodegenerative diseases have a gut origin. So anxiety is there, autism, 90% of people from a 2019 study have autism, have a gut dysbiosis or a gut issue. Alzheimer's and Parkinson's, which are autoimmune conditions, also have their origins in the gut. Dementia, multiple sclerosis has a dysbiosis origin as well. So these neurodegenerative diseases, a great way to add to some of your other blood tests would be to test for the gut barrier panel. So my clinical considerations: food sensitivity's effect on health, systemic inflammatory response, skin reactions. We know the skin is part of the immune system, joint pain, muscle pain. I mean, chiropractor, naturopaths, other practitioners. I mean, someone comes in, 80% of Americans have lower back pain, GI symptoms, and brain fog. Interesting, anxiety, depression, and mood. There is a case study in this deck. I'm hopeful to get to it. The number one set of symptoms that were abated by the removal of food sensitivities was anxiety, depression, and mood. Number two, believe it or not, was gas and bloating and brain fog. So if you want to make that impact, that indelible mark on people's lives, especially those suffering from anxiety, depression, and mood, you want to take away those food sensitivities. Neurodegeneration and autoimmune, we talked about, fatigued, and I think I documented body composition issues. So the real question is, when do you want to use the food sensitivity gut barrier panel? I think that that's a great goal. Number one, I think we're going to use it on a myriad of patients. I don't know that many patients that don't fall in the category of wanting to test for food sensitivities. Obviously, pregnant women, we're not going to test them. I've even tested my parents. They're 90. Of course, my father listens to me. My mom doesn't. That's a whole nother conversation. So you do want to use the FIT 176. Not enough good quality, sensitive and specific food sensitivities tests. That's why the FIT 176 is utilized so often in my office. Gut barrier panel tests. I mean, I have a slide that speaks about post-COVID damaging your gut. Multiple things damage our gut. I think if we can keep our barriers, our brain barrier and our gut barrier in pristine condition, we're clearly going to be able to put people on a health path. How to interpret, I will go over that. And next steps. Next steps is the key takeaway with a food sensitivity is delayed appearance of symptoms, 72 hours. And I believe, again, it's a major contributor to hidden and chronic inflammation. So food sensitivities, it's no surprise when you have a leaky gut that you have a food sensitivity. Food sensitivities can cause leaky gut. I did not have a leaky gut. My gut at the time was in pristine condition. You can still have some food sensitivities. You could have some digestion problems, and more so than that, you don't have a guarantee that your immune system is 100% functional all the time. So you will see some food sensitivities without leaky gut. So let's really talk about and isolate the IgG C3D food sensitivity test. I believe that the key to the test is the ability to test for the complement cascade. This complement cascade is an old inflammatory cascade that people do not talk about enough. My medical brethren, when I bring it up, they said, you know what, Rob? I remember hearing that back in school. I don't talk about it with patients, but it's there. The essence of the cascade is this. We know that there's a production of antibodies, and the antibody that's critical is IgG. IgG is 75% of the antibodies. You have slides for this. I'll be the talk through slide. 75% of the antibodies. It's the smallest antibody. It passes through the placenta. It's able to get to the fetus. It is indicative of a longer standing antibody production. The interesting thing about IgG is it has 4 subtypes. Most companies study or analyze for IgG 1 and 2. KBMO does 1 through 4, with the key component being IgG3. IgG3 allows you to test for something called C3D, which is the most stable molecule in the inflammatory cascade, which obviously comes from the complement cascade. So you're looking at studying for antibodies and studying for inflammation. Now you're looking at the KBMO test as a dual pathway. Why did I use this slide? Take a good look at the right where the word lamina propria is. So the left side has leaky gut. The right side actually has autoimmunity at the gut level. If you have a compromised gut and you're getting autoimmunity outside the gut, ultimately you'll get some autoimmunity inside the gut. So you definitely want to test to see the status of where people are. Remember, it's a circulatory system. So again, this is a slide that you guys can all go over. Once again, the key component is C3D being the most stable molecule of inflammation in the body. Great little slide. Look at the left. Many of the companies happen just to study IgG 1 through 2 or even IgG 1 through 4. One of the difference makers, or maybe the difference maker, is KBMO's ability to study for IgG 1 through 4 and the complement cascade. So it's the idea of a dual pathway. Let's take a look at what the test does. I love the color coordination. It's easier for me as a practitioner. And what's more, the next step is it's easier for me to explicate to the patients because they see the colors. They see the numbers. You know, when you, without the colors, and they also see the graph, again, it's easier. It's more evocative for the patient, and they're able to follow. And red, everybody knows, means stop. Orange is close to red. Yellow's a little more off. And then you've got, of course, the lime green and the green. And also you'll see that those additives, which we talked about, and again, I think that's a great add. Those food additives are a critical add in the idea of looking at specific things like MSG, and if you will. Now, this particular slide speaks to the idea, some of the things that KBMO on the right tests for speak to the idea that food additives actually drive intestinal inflammation. What I like is the eclecticness, the newness. When you look at it, you're looking at dairy. Everybody's trying to get an alternative to dairy. I personally believe most people should be dairy-free. So now they're testing for sheep's milk. When you look at the fruits, now you're looking at some newer fruits like a monk fruit that's being used a lot, acai berry, the spices, clove, the additives like stevia. I happen to use stevia. I think stevia is probably the most used, or at least the most health-minded. additive in the body today, or that you can utilize. Coconut oil, people are using a profusion of coconut oil, hemp. So essentially chia seeds, you're really seeing an up-to-date version. You're not seeing just turkey being an ad. Real question is, why does defective epithelial barriers lead to chronic diseases? Well, one, it does. You can see the list. And two, many of these diseases are attributed to changes in the microbiome and leading to autoimmune issues, neurodegenerative, and metabolic disorders. So again, that idea of, as I said before, testing, not guessing, really ramps up. So the question is, why would we test for increased intestinal permeability? Well, one, it's a standardization. So the non-medical, like chiropractors and naturopaths, sometimes we don't do as much blood tests as we should. I'm seeing a great growth in the medically adjacent fields. I'm part of it. In addition, you want to be able to express to the patient where you are. And some of the bigger things is patient compliance. When you show them what they have wrong, and this is a videotape, it's a snapshot time videotape, if you will. You're showing them what they have wrong. They understand. In addition, sometimes the symptomology doesn't abate, but the function and the structure begin to heal. Now you have an objective test. And we all know that blood is objective, whether it's a blood spot or blood serum. So now let's take a look at the gut barrier panel. So here we've got Candida. So Candida is a yeast. Everybody has Candida. Remember, the gut is an ecosystem. It's a neighborhood. You're going to have some different, some bad bacteria. It's just you don't want too much. Obviously, you're going to have some Candida. Again, you just don't want an overgrowth of Candida. So Candida is yeast. Zonulin is interesting. That is the protein enzyme that Fasano found. Now, the interesting thing about zonulin is that I believe, and James and I have had lengthy conversations about this, we believe it's a stable, systemic marker for overall health. And I believe with the growth of longevity being the conversation of 2023 and maybe beyond, one of the markers that I utilize for longevity is zonulin. Here's an epithelial cell. Here's an epithelial cell. They come together and they make a tight junction, real tight. Zonulin is the functional pull from the inside, my thumbs are inside, and pulls apart these tight junction fibers. So it's a functional pull. The occludin is the fibers and the tear. You're going to need some zonulin to have some occludin typically. And lastly, LPS. He's the bandito. He is the bad guy. He is an endotoxin inside the gut. Once he's expressed, I won't say the world, your world goes to a hell in a handbasket, but LPS is very detrimental because it's a direct binder and has been shown to damage different organ parts and or even damage organ systems. So let's take a look at what this gut barrier panel means and how I would explain it, sharing it with you. Obviously, we have IgA and IgA 1 and 2. I have some slides coming up to delineate them, which you guys can read. We're going to share a copy of my slides without question. So IgA is a mucosal level antibody that's produced, mouth, lung, and most predominantly at the gut. It's an early onset at the mucosal level. IgG 1 through 4, I think we talked about enough. IgG is over a duration of time. It implies that you've had this issue 14, 21 days and longer. But the secret sauce to it all is IgG 1 through 4, which also the FIT test is testing for C3D. So essentially, you're producing antibodies and inflammation together. So there's no question that if you have a Candida overgrowth, if you're expressing zonulin, occludin, or LPS, what it's doing to your overall physicality. So in what you're seeing here is an increase both in Candida from IgG and IgA and C3D. So they've had it for a period of time and it's still working at the gut level. Zonulin, however, has a negative to IgG 1 through 4 and C3D. So zonulin is an early onset positive for IgA, which makes sense because occludin, the structure, is all negative. LPS, no surprise, is negative for IgA 1 and 2, which really implies that it didn't damage at the gut level recently, but it's positive for IgG 1 through 4 and C3d. So if I were to tell you and we were to discuss this patient has a lot of issues. They're definitely going to need to adhere to my 7R program and some other things. So hopefully that was epigrammatic enough for everybody. IgA1 comprises 85% of the IgAs. IgA2 is 15%. It really speaks to LPS antigens. IgG is 75% of immunoglobulins. 2 critical points. The half-life of IgG is 21 to 23 days. I like an elimination of a food sensitivity diet for 12 weeks because I like 4 half-lives. There are some practitioners that do 6 weeks, 2 half-lives. My preference is 12 weeks, 3 months. Again, Candida, but the real takeaway is that it grows when good bacteria is suppressed or your immune system is weakened. So Candida really implies a lot more than just, obviously, yeast overgrowth. Zonulin, that's a protein that opens the tight junctions. Check this out. Fasano found, and he stated that gliadin, the protein in gluten, increases the release of zonulin. So the data is interesting, and I don't want to belabor the gluten point. I'm a gluten-free advocate. That people, whether you have celiac, obviously that's an issue. This is a 2015 study. Whether you had celiac remission, whether you had non-sensitive gluten sensitivities, or none of the above, which would be 60% of the population, the fact that gliadin opens up zonulin makes us pause for concern for gluten. And also intestinal bacteria open zonulin. So that's a double whammy, if you will. Zonulin is interesting. It's a protein synthesized in intestinal liver cells, key biomarker for intestinal permeability. Elevated cells or elevated levels of zonulin are associated with the multitude of conditions: autoimmune, celiac, IBD, obesity, multiple sclerosis, type 1 diabetes. As I said before, I believe the expression of zonulin is not just a health and a systemic health marker, it's a longevity marker. In addition, higher levels of zonulin are associated with blood pressure, obesity, and waist circumference and fasting glucose. This was a new ad that I just found. Zonulin levels are increased in many Alzheimer's conditions. It makes a lot of sense because the gut is implicated in all these neurodegenerative diseases, and Parkinson's and Alzheimer's have a gut issue, but they're also autoimmune. Occludin. Occludin was the first transmembrane protein of epithelial tight junction to be discovered. What I like about it, if you could look at the occludin at the bottom, it shows that occludin is such a structural key component because it works and it's connected on both sides of the epithelial cell. So occludin is a key biomarker for intestinal permeability. The barrier function is there to regulate transport. Occludin is opened because of zonulin, and elevated levels really show a progression of damage of intestinal permeability. So my key gem, occludin in tight junction stability and barrier function. Together, occludin and zonulin are the gatekeepers of the tight junction. If you have zonulin, ultimately you will have occludin, and occludin is a great ad. They added that some time ago. I think that it gave even more validity to the test when that was added. LPS. Let's take a few moments for LPS. Major outer surface membrane components present in almost all gram-negative bacteria. 80% of gram-negative bacteria is pathogenic. LPS is a strong inflammatory stimulant. It also stimulates the immune system. It crosses not only the gut, it also crosses the blood-brain barrier. And when it does, it can trigger a myriad of different kinds of inflammatory cytokines. Interesting. This is your gut. Over here is your blood, and over here is inside your gut. The little bridge between the gut microbiota and immunity is LPS. It holds that gram-negative bacteria on the inside of the intestinal wall. What's interesting is that when LPS is inside the body, it stimulates interleukin-10, which is your anti-inflammatory interleukin. Conversely, by doing so, it decreases interleukin-1 beta, interleukin-6, interleukin-8, TNF-alpha. Unfortunately, When it's outside the gut and the gut is leaking, LPS is expressed on the bloodstream. It now turns off the anti-inflammatory interleukin-10 and turns on all the pro-inflammatory markers. So one of the questions that's typically asked, in a practice setting is, do you do these tests alone? You can. Do I do these tests alone? I typically mix these tests with typical blood comprehensive chemistries. And what I found that this study is correct in my practice setting. When LPS is expressed, the patient has inflammatory markers through the roof. LPS can show that the gut speaks to the brain and the extremities. And here are some of the structures like thyroid, metabolic disorders, lung, brain, liver, and joint. So LPS really expresses the idea that the gut is able to communicate with the periphery. I put this slide up really to talk about how does LPS cause inflammation. It does so because it stimulates the NLRP3 inflammasome. That inflammasome increases all those interleukins, 1 beta, etc. It also damages the mitochondria. One quick treatment note. LPS, well, the first thing you want to do is obviously fix the gut. But if somebody has an LPS problem, and you're concerned that LPS at signal 1 is touching toll-like receptor 4, which stimulates the whole cascade, omega-3 fatty acids blocks LPS from attaching toll-like receptor 4. And signal 2, it's a dual signal, ketone bodies attenuate the signal 2. So I just wanted to give a real quick treatment protocol there. And gut permeability equals to more endotoxin absorption outside the gut. For me, I ask all my patients, have you had COVID recently? Have you had COVID-19? Because the data indicates, the data is actually unfortunately robust, that inflammation promotes excessive gut permeability. Viruses are shedded through the gut. They're also stored in the gut. So there's been shown in blood serums that an increase in tight junction permeability is usually present in COVID, especially long COVID. Increases in zonulin, occludin, and LPS are present. So if you're wondering who else you should ask or what else you should ask and which patients you should give the gut barrier panel to food sensitivities test, you really want to ask those who have had COVID-19, which I think is about 80% of the American population. So let's get into the concepts of some cross-reactivity. Many companies, unfortunately, we're not here to bash anybody else, are not testing for zonulin antibodies. They're testing for haptoglobin. Some are actually talking about zonulin levels in stool tests. Bottom line is, let's run right to the bottom. It's a serum or a blood spot that you want. Stool tests are not as accurate as testing for the zonulin and the zonulin antibodies, which really eliminates a lot of the cross-reactivity and gives them more appropriate positive rates. For me, there's some tests that find nobody, and we know that people have leaky gut, and there are some tests that find 90% of the people have zonulin. That's just too darn much. So here you're seeing this beautiful layout, this beautiful color-coordinated cascade. On the left, again, you're seeing the food sensitivities. On the right, you're seeing the gut barrier panel. So you can refer to one and the other and really correlate food sensitivities, sensitivities to additives and emulsifiers, and the status of your gut. So the takeaway, if you had to remember one slide to share with your colleagues and or your patients, is why would you use the test? Well, it's a dual pathway test. It's testing for auto-acquired immunity because it's measuring antibodies 1 through 4 in IgG. It's also testing the innate immunity, which measures complement C3d. So it's food sensitivities, inflammation, and gut permeability all in one test. I am not going to give you a lecture now in the interest of time on the immune system. However, there's really 3 lines of defense in the immune system. Line number 1 is the barrier system. It prevents entry. And such is really your digestive tract. It's everything from your mouth through your anus. That's the first line of defense. So if you're testing your gut and your digestion, the FIT test with the gut barrier panel is testing that. Your innate immunity, you're testing that. Those are neutrophils and macrophages, your ability to test for inflammation. That's also tested by the testing for the C3D. And lastly, your acquired, your adaptive, or your specific defense, making antibodies, you're able to test for that in the FIT 176 gut barrier panel because you are testing for antibodies. So for me, if I may share, I also discuss the concept of immunity with my patients and a test that covers all three lines of defense. One little additional side, and I didn't mean to go quickly over it, the concept of IgG3 stimulating C3D. I did not know till I learned about this test, full disclosure, that an antibody could produce inflammation. I really thought it was inflammation and then antibodies. Inflammation, antibodies. You know, the T cell will tell you who the bad guy is in the acquired immunity, and the antibodies would memorize it and catalog it. Well, the ability for IgG to stimulate inflammation makes sense because if you have an overabundance of antibodies, you still need some inflammation to handle the onslaught of the pathogen. So that's also a concept that a lot of docs may or may not remember, and certainly patients don't understand that. So once again, it's a three-line of defense to have your immune system work in a pristine condition. Clinical studies, the basis here is there's a test before the elimination diet and a test after. An elimination diet is something that you do after you take away your food sensitivities for a period of time. There was a dramatic change in many, I should say all, but a dramatic change in many symptoms. At the top of the list was memory, concentration, anxiety, mood. 2 was bloating and brain fog and fatigue. So you can see the percentage. This was just taking the food out. This was not fixing the gut. This was not giving digestive enzymes. So imagine when you couple that in concert with some of the suggestions that I have and some of the suggestions that you guys already are implementing. So the basic premise is IBS severity score. So you saw the removal in the control group and the intervention group, the combination. So the control group kept the foods in, the intervention group took it out. It was 3 times more effective taking the foods out, 3 times more effective in an IBS severity score. Homocysteine, a stroke marker, without question, a marker that everybody needs to address. The control group went up when they ate any food that they wanted. When they took out the food sensitivities, the intervention group decreased. Look at the difference. It was a dramatic difference. And of course, C-reactive protein, tissue inflammatory marker, 5 times the decrease in the intervention group versus the control group. So the breakaway theory here is the removal of food sensitivities not only decreased the symptomology, they also decreased blood serum inflammatory marker levels. So the FIT test resulted in twice the IBS severity score reduction compared with cellular test. The FIT test resulted in a 50% improvement in IBS severity score compared with tests that measure IgG only. The conclusion states it right there. Clinical outcomes from IBS greatly improved when using the FIT test to predict food sensitivities. So my conclusions on the KBMO FIT test, real simple, measures 176 foods, colorings, additives, dual pathway technology, IgG and complement. Complement, which again will generate inflammation, the test for C3D. Before we go any further, it really tests for the 3 lines of defense. It has and tests for appropriately the anti-zonulin antibody, which is a key marker of gut permeability. Now testing for LPS, like I said, the banded, the endotoxin, and it has that unique gut barrier panel now included. It has a clinical outcome backed by an IRB and some other studies soon to be seen. And maybe the ease, the practice management ease. You can also use a finger stick, a blood spot. I call it like a little thumb prick, same as when people test with their thumb for glucose. So it makes it easy in an office like mine because I don't draw the blood. I always have a phlebotomist draw the blood. You can also, when you, and we're talking in part 2, the virtual patient, you can send it to a virtual patient. It just makes for ease of dispensement. Also, the FIT has a phone app, and on the phone app, what I like about it is patients come in and they can go, okay, so here's my list of foods. Here's my cell phone. Here's my list of foods that I am not supposed to eat for the next 90, 120, 60 days, whatever. And here is a meal plan that KBML supplies if you'd like it to be shared. So here's my 7R program. I want to do this very quickly because I want to get to some questions. The 7R program, and James will send you the different products that you could put in. The basic premise is you want to reset your diet, your lifestyle, and mindset. You want to take away all the foods that pose an issue. You want people to start having a discussion that health is wealth. You want to remove unwanted pathogens. This is where you take out your food sensitivities. This is where you use your oregano oil, your berberine. This is where you also use your serum bovine immunoglobulin and any kind of biofilm busters. I think that to give this its due justice, James and I may have to get back on and do a webinar just on the 7R and how it applies to the gut barrier panel and fit digestion issues. Replace. You want to replace digestive enzymes, stomach acids, add bile, and pancreatic enzymes. You want to regenerate damaged intestinal mucosa. That's step number 4. You want to heal and seal the gut lining. You want to use pleiotropic nutrients that allow for anti-inflammation and do heal and seal the gut lining. You then want to re-inoculate with pre and probiotics. I'm a big proponent of taking a pre and a probiotic to make what we call a postbiotic. Here is your reintroduction and or your retest phase. I do like to retest after 90 days. If you're not comfortable with that or it just doesn't work in your practice management, that's fine. You can reintroduce the foods. It's one food sensitivity food that was removed every 3 days, and you want to see if the symptomology comes back. If it doesn't, move on. And lastly, retain your health and GI integrity. I recommend a multivitamin, a multimineral, an omega-3 fatty acid, a vitamin D3 with K2, pre and probiotic, and some shake, a collagen shake, a fruit and green shake to help populate your gut bacteria and help heal and seal and keep it closed, your gut lining. So people ask me, okay, if Candida is elevated, what would I recommend? Well, caprylic acid, oregano oil, berberine, garlic, and SPI. And I like the lactobacillus strain of probiotics that I would add because they produce lactic acid and they do a great job with fungal compounds. Zonulin and occludin, very specifically, if you want to get granular with the particular ingredients. Probiotics, Belongum, zinc carnosine. Zinc carnosine is without question the heavy hitter. Zinc carnosine activates the NRF2 pathway, which is a key antioxidant pathway in phase 2 of liver detoxification. It's shown to really lessen the damage of gut permeability and really help knit the gut barrier panel, especially at the tight junction level. L-glutamine, collagen peptides, curcumin, and glucosamine HCl. And lastly, I really want to finish with a case study and then open up for questions. Here was day 1. Someone came in on a Fit 176 gut barrier panel. They had 4 reactions that were 4 or plus or more. So they were heavily sensitive, generating a lot of inflammation. They had 3 reactions to a 3+, something of concern, and still something to make note, a 2+ reaction. So you want to take out your reactions that are generating a 2 to a 4. Just as an FYI, they still have some low-level reactions, and there were 7 foods in the low-level reactions. I did not take those foods out. I simply did my Dr. Rob 7R action plan, removed those 9 foods, and I retested in 9 months. Excuse me, I retested in 3 months. At the same time, here's the gut barrier panel on day 1, positive IgA 1 through 2 for Candida, zonulin, and occludin, and LPS over a duration of time. So I said because of LPS being positive for IgG 1 through 4 and C3D, I was going to do the Dr. Rob 7R program, but I would reevaluate in 6 months. So 91 days, I retested, and they dropped down to, they went from 9 things from reaction 2 through 4 to only 4 things, but I had no level 1 reaction. Now, I'm sure when I get James on in a moment and I ask him how many people have 4 reactions, he'll say a very small amount. And then next step, gut barrier panel, perfectly clear at the 6th month. Now, I usually test and retest after 3. Again, some docs do 6 months. If I see LPS, and this is a little practice management gem or nugget, if you will, I believe it's going to take 6 months for LPS to be removed. And food sensitivities, there was just one food sensitivity then. I mean, for me, I've never had a patient not have a food sensitivity. So let's give it a thumbs up. Let's get to the idea. The most effective clinical outcome across all disease spectrums can result from the normalization of gut function. Here's a patient that has a normalization of gut function. And once again, take a look. If you're interested, try it for yourself. There's no doubt. I'd like to pop James on. We've got 13 minutes. I have no problem going over time, but I'd like to pop him on. I'd like him to address this, talk about this just for a moment, and then let's get to all the questions. I see there are a lot of questions.
We've got some questions for sure. So yeah, that offer still stands. So let's go through some of the questions we've got here. One good point was made about, where does dental bacteria fit in here? It's interesting. I was at a conference held by BioHealth about 3 years ago down in Mexico. They're a great group of conference organizers and pharmacy down there. They were already talking about that. So, Dr. Rob, a quick point on where does the dental bacteria fit in, and then we'll go into some other questions.
That's a great question. In my new presentations, we do talk about the gum bacteria. It's the second largest microbiome in the world. After your skin microbiome, there's a direct correlation to your gum bacteria. And Alzheimer's, 90% of Alzheimer's patients have gingipans, and there's a bidirectional communication between your gum and your gut. So without question, your gut, as we said before, is the epicenter of health. How do you not test for it with all your patients?
Perfect. Another one here. It says, why do you not test pregnant women? Well, sorry, can I correct that? We do. Have you done much testing with pregnant women? Maybe not your field exactly, but have you heard anything around that, Rob?
Yeah. James says you can, and I agree. I'm just, I happen not, first of all, I don't treat a lot of pregnant women. So I don't have a lot of access to data, but you can. I want to be corrected. I'm sorry that I misspoke. And listen, I mean, we don't do enough for our pregnant women here in America.
Here's another one here. Would it be advisable to test after some of the leaky gut issues such as diarrhea, SIBO, SIFO, and then would COVID-19 need to be severe to have complications stroke leaky gut?
Well, I'll do the COVID first. The severe COVID definitely was much more detrimental. It was more damaging. However, for me, I don't want to take a chance that I missed something. So everybody who had a positive COVID-19 test, I tell them that they should at least take the gut barrier panel. But I believe you really want to synergistically take the food sensitivities with it, because if you have leaky gut, you want to know what foods to remove to help heal the process. Now, I think the other question was C. diff and all that. Would you take a gut barrier panel? Absolutely.
Yeah.
Without question. I would want to test for that.
Please address high eosinophils. Have had 2 patients recently with elevated levels. So the question I said, well, did you run the test on them? And the response was no, not yet. So I know there's generally 5 foods or something linked with eosinophils. So, but Rob, I don't know what your thought on that one is.
I would run the test. I think so. In a nutshell, for full disclosure, if a patient comes in, here's the 2 things that I'm going to run on every patient. Number 1, I'm going to run a full comprehensive blood lab, as comprehensive as I can. It's going to be very lateral. It's going to be very vertical. It's about 22 different vials. I'm also going to run the FIT test with the gut barrier panel. Those are my bases. So I think that when you look at all those together, for me, that's the standard point. There are other tests you could do later if you'd like, but those are the 2. And as you can see, if you had both tests, or if we have all the tests that I'm talking about, the comprehensive blood chemistries and the FIT test with the food sensitivities and the gut barrier panel, we can now see some clarity in the puzzles of their health.
We'll skip this one because he wasn't very clear on which test he was using, which wasn't very helpful on that. But a question here, I have a patient with no food sensitivities and leaky gut. and also patients with food sensitivities and no leaky gut. Why is that? How do you interpret that?
So I assume you just said no food sensitivities, but leaky gut, and food sensitivities and no leaky gut.
Yeah.
You know, the one thing I learned about when I left school, and I hope this helps you get around it, is that people are different than what the book says. So I have food sensitivities. James knows that. I'm very happy to share my tests with everybody. I think I had 8 of them or something like that, and I had no leaky gut. And I'm happy about that. So I removed the food sensitivities. I do believe everything is fluid. So, I don't know that everything stays the same, and we were on a circle called the Earth. Now, to speak to the gut barrier panel and no sensitivities, well, one, that's a good thing. It should be pointed at the gut barrier panel and getting it fixed. And number 2, I'm pretty sure that if it was not addressed, if you do nothing, you can't expect your health trajectory to change in a positive light, that they ultimately would have some food sensitivities. And with the gut barrier panel, if we're correlating with inflammatory markers, I think you would see an elevation. So why is really interesting, but what it does for you and what it reveals, I think, is more telling.
Yeah, I mean, one of the other things was one of the reasons we added those 4 markers in the measuring the IgG as well as the IgA is because we view it more as a continuum. So again, to Rob's point, it's a snapshot. So sometimes, it'll show up, other times it may not. But again, I think it's certainly directional, pretty helpful. And that's interesting you've seen that. I don't think I've seen a test with that kind of clarity in terms of yes, no, in terms of sensitivities versus.
James, what percentage of people have you seen that have no food sensitivities?
Very small. I mean, that's my point. I don't think I've ever, maybe a handful in the hundreds of thousands of tests we've done have had no sensitivities at all. So
yeah,
I'm not disagreeing with that. I find it slightly mildly surprising that we haven't seen that. Good question here. Did the patient in the case study add back the foods they reacted to before the second and third tests?
They added back the foods at the 90-day, and that's why I retested again, because whatever foods they were retested and were not sensitive for, we put back in. So I'm not going to promise you that, let's say you have 10 food sensitivities, that they'll be able to eat all 10 foods. But let's make a very salient point right now. Having a food sensitivity does not mean removing the food for perpetuity. There's a large percentage of the foods you'll be able to get back. In this instance, this person worked real hard. We were fortunate. Everything worked that we did except for 1 food after 6 months. So when you look at it, that's about the level that you can be able to get the foods in. It's 75+%. Not everyone typically, but some. Remember, we have a functional digestive system. We're under a tremendous onslaught. There's tremendous toxins out there. There's glyphosate. And I don't want to go out on a diatribe and stand on my soapbox, but we are under tremendous strain in America from environmental toxins in foods and ultra-processed foods. And that really makes it just a little harder for us to get the perfect results that we could have addressing the test and, of course, the protocol and answer.
Another question which I can take comfortably: will the $200 test work for existing clinicians? Absolutely. So if you've never run the test on yourselves or any of your staff members, always happy to kind of offer that to existing clients for sure.
I will tell you this, having your staff, or in my instance, my wife runs my office, having her take the test and discussing it in the front with patients. And, there's something about going through the process that gives a absolution and you look more resolute and when you talk about it. Now, obviously, I don't want to go through brain surgery to know that that surgeon's good, but a test like this was, again, revealing. And a lot of my patients ask me, hey, did you take it? And I said, yeah, here's my results.
Okay. Why sometimes a patient has a sensitivity to a food that he or she have never eaten?
Great question. I don't eat sardines, but, I found out, well, first of all, sometimes the foods they don't eat, they're still sprinkled somewhere else. For instance, my example was I was sensitive to sardines. I hate sardines. Yes, they're healthy. I just don't eat them. The fish oils that I consumed were made from sardines and anchovies, not realizing that now I use a salmon oil product. Remember, it's a sign that there's something wrong with your digestive tract if you have a food sensitivity, something wrong with your gut barrier, and or there are some dysfunctions in your immune system. So you don't necessarily need to eat the food to have a sensitivity to the food. You don't always are necessarily sensitive to a food that you eat every day, like eggs, although it is a high allergy food. And James, I think would be great for them, now that I think about it. You have a list of 8 foods that are most commonly found positive, or I have a slide in here of the top 20 foods. I think that's a great give and look for all the practitioners that are utilizing your test.
Yeah, the other point on there, Anita, is more importantly, sometimes what you need to do is we provide the provider's guide to all of you, and within the provider's guide for each food you'll see cross reactivity. So it may be that on some of those foods there may well be some cross reactivity going on. So again, generally for 95% of patients we wouldn't talk about sharing the cross reactivity on each food, because that can sometimes lead to issues in terms of overwhelming a patient. But again, on the specific food that they claim that they're not eating, then that would be a point. But Rob makes a great point there. It's like it's what they think they're eating versus what they're really eating. So again, in terms of making sure they're checking really what's in 3 different elements that we always think about. Processed foods, and Rob touched on that in terms of the amount of processed foods being consumed, not only in the US, in the UK. I'd include the UK population in that.
You made a good point. I'm not trying to interrupt you about cross reactivity, and it's not for this webinar. I think that's a webinar that we should discuss. But if you're looking for cross reactivity, that's a fascinating concept. However, now there's a belief, if I could seed you for a conversation, everybody, leaky gut is now leading you to pre-autoimmunity, hence the idea of cross reactivity. So again, this test will portend a lot of failing health issues in the foreseeable future.
Yeah, and so just kind of picking up on my point with the processed foods, also supplements, as Dr. Rob pointed out, on the 176, we added mackerel, sardines intentionally because you find them in a lot of omega-3s, and a lot of these patients are inflamed. So the idea is, let's test them ahead of time to make sure, unbeknownst to you, let's not put them on a supplement that actually is causing them an issue. So think of processed foods, think of the supplements, and thirdly, personal hygiene products. So again, they are, benzoic acid is unfortunately alive and well, and you will find that obviously on the test, but more importantly, it's in washing powders, it's in shampoos. And the other point I would say is, some practitioners say, well, I actually look at an elimination diet versus doing food sensitivity testing. I would strongly believe there's no elimination diet out there that says, let's eliminate benzoic acid from your diet. So the idea is, by looking at these colorings and additives, gives us another dimension on just the standard foods that patients are consuming, and thinking of the world slightly differently, as I say, in terms of the supplements, the processed foods, and those personal hygiene products. Catherine, I've been trying to buy time here because I was texting with the UK office to find out what the offer we do at trade shows there is. So as soon as I find that out, we'll make sure that. But it's there's definitely a sterling option. The way sterling's plummeting right now, we probably want to keep it in dollars for you guys. But we'll see what we can do and make sure that we understand that one as well.
Those healthcare problems really indicate also, ladies and gentlemen, because the gut and the liver are intertwined, that toxic overload, which can damage the gut. So, I mean, again, there's a lot of depth to what we just discussed.
Aaron's got another great question here. Do you have patients reintroduce gluten and dairy, or recommend they stay off them long term? I know you touched on that a little bit in the presentation.
Yeah, I mean, it's very funny. I was just lecturing in Wisconsin, so I got out there, and the first thing I told them all, and I'm from New York, if you couldn't, didn't see my accent and my mannerisms, and I just told them everybody should be dairy free. Wow. However, I'm a big proponent of gluten and dairy free, and we can go to more detail in that if you'd like. But those are some absolutes. So I have a couple acronyms: GPS, no gluten, no processed food, no added sugar; DNA, no dairy, no nicotine, no artificial sweeteners, no deep fried foods, and no vegetable oils. And obviously, if you combine that with taking out your food sensitivities, I think you've got a real solid list for patients to follow to really help them on their health trek.
Great talk. Thank you very much for that, Kenton. Anita, when are we going to make the slides available? Like I said, if not later today, probably early tomorrow morning. What if you have someone sensitive to polysorbate 80 or other additives that are in RX, so are in pharmacy, are in drugs? For example, hydroxychloroquine for RA. Do you suggest taking them off the RX or just heal the gut and retest? So just our general advice on drugs generally is what we say to patients and providers. If you're on a long-term drug, then that's kind of your new norm. So obviously we're not recommending coming off any drugs. However, if you're on a short course of 2 to 3 weeks, once you finish that short course, basically wait 3 weeks, then run the test. So that's just some general advice versus on that. And again, I think when you look at some of the, as you say, colorings and additives that are in pharmaceuticals, again, it's another thing to bear in mind in terms of it could be causing an issue, but we're certainly not kind of saying that you should come off any of those pharmaceuticals that have been prescribed for you. Dr. Rob, any thoughts on that?
I concur with you. I mean, I believe that we live in a world of everything is risk and reward. So you have to determine the risk and the reward in that. And again, a lot of practitioners, myself included, really don't touch on the drug thing. That's more for the medical model to really get involved in that. But I feel your pain on that.
Yeah, and I would say we wouldn't say that about probably supplements. So definitely look at the supplements that you're putting your patients on. And Dr. Rob mentioned it when we went through the Fit 176 in terms of those additional foods. You have acai berry, monk fruit, stevia. They're in a lot of those powders. So the idea was, let's make sure we're testing that up front rather than just assuming that all things are good for all patients, which, as we all know, is that one size fits all model doesn't really cut the mustard. So hopefully that's helpful in terms of that RX. But a great question. So thank you very much indeed for that. Thank you very much. That's excellent. Perfect. So yeah, so thank you all for your questions. Very, very helpful. And Dr. Rob, again, thank you so much for your excellent talk. And as I mentioned, that discounted offer is available, and we'll be getting the slides and this talk out hopefully tomorrow morning. If not tomorrow, certainly the next day. So the idea is to get that out to you whilst it's hopefully still fresh in your minds. And for those who couldn't join as well, it'll be easy for them to kind of follow on as well. So thank you all very much for your time. And Dr. Rob, as ever, thank you so much for all your great questions and going through all those great slides.
My pleasure. Always a pleasure to work with you. Hope to see everybody soon at part 2.
Excellent.